Welcome one, welcome all. We're going to give it just another minute or two to let some of these folks jump out of the waiting room and into the Zoom. All right, folks, I've got 4 o'clock. We'll go ahead and get started. Well, good afternoon. And on behalf of Voices of Hope and the Healing Community Study, I want to say thank you for attending our learning collaborative entitled Come As You Are, Transformational Housing. I'm Dr. Alex Ellswick. I'm an assistant professor at UK, a co-founder of Voices, and a person in recovery. So I feel that I'm squarely in the middle of the boat among all my people here today. I can tell you that at Voices of Hope, there's been a lot of excitement about this learning opportunity, particularly among our recovery coaches, who frequently tell us that housing poses one of the greatest barriers for the people that we serve. And I also know this from personal experience. As a consequence of my addiction, I was cut off from my family and from my girlfriend. I went in and out of treatment centers, and on at least 2 occasions, I was kicked out of a treatment center and out of a halfway house because I was unable to stop. The problem wasn't that I was kicked out of these treatment centers. I believe they have every right, and indeed probably an obligation, to create these spaces that are safe and free from drugs for the folks they serve who are in abstinence-based recovery. The problem for me was that when these abstinence-based treatment centers didn't work for me, I had no alternative. And as a consequence, I found myself homeless at 22 years old and sleeping under a bridge in Dayton, Ohio, and shooting heroin and sharing needles. And some of the worst experiences that I had in addiction, some of the darkest things that happened to me happened while I was vulnerable and homeless. And I'm here today because I believe that something else is possible. I believe that that didn't have to be the case. And it's unfortunate that my story is not uncommon in this part of the country. Almost all of our supportive housing options are abstinence only. Many times recovery housing even excludes people on FDA-approved medications for opioid use disorder. But something different is possible. And today we're here to learn from state, national, and international experts on harm reduction informed recovery housing options. We'll listen to our panelists for about an hour, and then we're going to split into breakout groups so we can brainstorm some first steps to put these lessons into practice. And my first question is for Dr. Bernie Pauly. Dr. Pauly, thanks for joining us.
It's really great to be with you. Thank you so much.
We're glad to have you. Dr. Pauly is a professor at the University of Victoria College of Nursing, a scientist with the Canadian Institute for Substance Use Research, and a research collaborator with the Greater Victoria Coalition to End Homelessness and SOLID, Society of Living Illicit Drug Users. The primary focus of her research is reducing health inequities associated with substance use, poverty, and homelessness. It's a pleasure to have you with us. Dr. Pauly, you've written in the past that one size does not fit all when it comes to housing approaches. And here in Kentucky, abstinence from drugs and alcohol is required for nearly all forms of supportive housing. So can you begin by talking about the role that harm reduction and housing first strategies could play in ending homelessness?
Thanks so much, Alex. And I just want to acknowledge so much your story that you shared, because you're right. It's a story that many people in their own unique way have experienced it. And I think, you know, what you described is there's this continuum of care, or this idea of readiness for housing, where you have to be abstinent or sober first. And you know, many years ago, through really the Pathways to Housing in New York, that got turned on its head and said, you know what? The best place for people to recover is in housing. And so rather than saying you have to be free of drugs and alcohol, housing first was introduced so that people can be directly housed from the street where they're at, regardless of substance use. And if you kind of put that into a bigger context, we can think about the fact that, you know, there are very few people who live in abstinence-based housing. You know, in Canada, I'm on the very west coast of Canada. You know, we have probably 70 to 80% of the population who use some form of drugs or alcohol. So it's just a much more kind of pragmatic recognition of, you know, the fact that you don't have to earn housing, you don't have to deserve housing. We can meet people where they're at. But that gets kind of confused a lot of times. And I'm an academic, but I'm a community engaged researcher, and I work really close with people in the community and organizations that sometimes these kind of really simple kind of evidence-based ideas about directly housing people kind of get confused with a whole bunch of other things. So I put together this slide. It takes quite a few things from one of our national organizations called the Homeless Hub around housing first. And housing first doesn't just mean we're going to put people into housing and leave them unsupported. It's really about providing a range of supports and that are suited to that individual based on their needs and self-determination. And since that first, you know, work by Pathways to Housing in New York, Canada has done one of the largest trials of housing first in the world. It was actually a randomized control trial, and found really high success rates with housing first. Over 80% of people retaining their housing when they're directly placed into housing. Now, one thing that's interesting is that study was definitely prioritized people who would have been identified as having more so mental health issues. And we know, you know, we've learned a lot from that, but we've also learned is when it comes to substance use, it can't just be anything goes. And so harm reduction in a housing first approach is one of the supports that people need. And harm reduction can be part of a recovery orientation because it's not, because it's focused on preventing harms. So not preventing or not demanding abstinence, but rather focusing on meeting people where they're at, encouraging positive changes. So success can look like a lot of different things. It may be using safer, it may be eating better, it may be keeping housing. And so it's really looking at a broad range of alternatives to expecting people to stop use. And I just want to, we're going to talk a bit later, I think, about cost effectiveness. And, you know, when you look at that kind of continuum approach, or what some people call readiness, that you have to go through, you know, you have to go to a shelter, and then you have to go to a transitional setting, and then you have to, then you can get housing. That's actually a more expensive approach. Shelters are typically more expensive than housing someone. And I think many of you will know what I'm going to say next is shelters are not great places to recover either. You know, I work here with a lot of people who've been living outside and, you know, we've done some research and looked at what's pretty well known in other places is that, you know, shelters are often not safe places for people. They're communal living. It's hard to recover in that kind of setting. And, you know, Housing First really puts forward the idea that, you know, permanent housing and supports are a fundamental human right. And harm reduction, and we can talk a bit more about what harm reduction looks like later, is actually a key piece of that in terms of assisting people to stay housed and to recover. So thanks for the question.
Can you sort of paint a picture for us of what low barrier housing looks like in practice, and maybe some examples of the model?
Yeah, so I'll just give you a couple examples. So we've got a range of housing settings, and in those settings, there would be a variety of different types of harm reduction services. So, you know, the first thing is that you have to have policies that embrace harm reduction. So you can't have a housing program that says no drugs and alcohol on site and then gives out safe supply. That's a contradiction. And so looking at, you know, the policies in a housing program is really important to make sure that they line up. And the other thing, I mentioned this earlier, it's not an anything goes approach. Yeah, we allow people to use drugs and alcohol on site, and whatever happens, happens. That's not what we're saying either. Harm reduction is an evidence-based approach that provides a set of strategies for safer use. So that can look like providing safer supplies in your building. In many of our buildings, we have what's called overdose prevention sites, which are really a very low barrier, lower cost form of a supervised consumption site. We have some programs that provide people with alcohol, but also help them to manage alcohol use, you know, as needed. So, and this could happen in supportive housing where people have their own units. I mean, obviously that's the ideal kind of setting. Right now, during, I guess probably it's been about a year, I live in Victoria, which is like very, very West Coast, South Vancouver Island. And our city purchased about five hotels. I might not have the number right, but it's about the equivalent of about 350 hotel rooms that were repurposed for housing. And there was a very deliberate, focused effort to integrate harm reduction, because in British Columbia, if you're not aware, we're actually in year 6 of a declared public health emergency to overdoses. So very big concern that when people move directly from outside to inside, that could increase overdose rates. Because outside, and I'm sharing from our experience, is, you know, people were living in groups. They were in a community. They were able to support each other around things like the use of naloxone, for example, and being available. And you move someone into housing, you have to really carefully think about the harm reduction interventions that are available. So those are some thoughts. I hope that touched on what you were thinking about, Alex. Thank you.
That's terrific. Thank you, Dr. Pond. My next question is for Lisa Grillo. Ms. Grillo has been with Seattle's Downtown Emergency Service Center. DESC helps people with complex needs of homelessness, substance use disorders, and serious mental illness achieve their highest potential for health and well-being through comprehensive services, treatment, and housing. Ms. Grillo, thank you for joining us.
Thanks for having me, Alex.
You've shared that supportive housing is about much more than just a building. And can you begin by telling us about your program at 1118 Eastlake?
Sure. It's actually 1811 Eastlake, very close. A little bit of history of that particular program. That building opened in 2005 and had a lot of pushback from residents in the neighborhood, from the media, and the premise of opening that building is King County, which is the county Seattle is in, identified 75 of the most highest utilizers of emergency room services, sobering center, and things like that, and offered them an apartment. And at the time, 73 of them accepted. The other 2 eventually did move in not long after that. And after a year, it's been studied very heavily, and the University of Washington has been very involved in researching 1811. After the first year of operation, The county actually saved about $3 million in the costs associated with taking care of those residents before they were housed. So that's, and I typically, the folks that live there are mostly folks with alcohol use disorder. We do a similar thing with alcohol monitoring there, which we do in all of our buildings, but we do it much more at 1811, where if we are that particular client's payee for their Social Security funds, we then purchase whatever alcohol they use. The client determines like how often they want to pick it up, and then we distribute it throughout the day or one time a day or however that plan goes. The thing about doing that is that we have to also consider their other needs, because in an alcohol monitoring program, that particular client doesn't get any cash. So we have to think about like, how are they going to get their groceries? How are they going to get hygiene supplies? How are they going to get other things? So we use some pretty creative approaches around that. And a lot of it involves like buying gift cards so we can order groceries for them online and things like that. So taking the clients places if they want to buy something in particular, so we're not actually handing cash to them. And what we've seen time and time again is that those folks are drinking less. Their medical issues drop significantly, and sometimes the behavioral issues tend to subside as well. So that's kind of how 1811 operates. And there's a portion of the building that on the first floor there, where there are actually 16 cubicles, that it's not really a shelter. It's actually considered housing for those folks. During COVID, we had to move half of them to one of the hotels we were using in lieu of a shelter.
Well, it sounds like you face some NIMBY issues, some not in my backyard, some resistance from the local community. Can you give us a sense of how you were able to overcome that barrier?
Well, I think it's interesting. You know, we always create, when we open a new housing project, there's always a good neighbor policy. We do a lot of work beforehand while we're planning. We're actually in the process of trying to build in a city south of Seattle, and we're getting a lot of NIMBYism there. We do a lot of like community meetings with the community. Sometimes they go well, sometimes they go horribly, but time and time again, we have 15 supportive housing buildings right now. We just broke ground on our 16th, and we found that, and the neighbors have found that we just integrate into the community. We move in, we participate in community activities. People get to know our residents, and then just realize that, you know, nothing bad is going to happen because our folks are moving into their neighborhood.
Can you tell us a little bit about the Come As You Are shelter model, what that means and what that looks like?
Sure, that would be called, that's our navigation center, and that's our super, super, super low barrier shelter that was from a RFP by the city of Seattle. And I want to say it was maybe 2017. That particular building, folks can go in with their partners, with their pets, with their shopping carts, with their stuff. And traditionally in other shelters, it's very limited in terms of what you can bring. Typically can't bring your pets, can't bring your partner. It's very low barrier in that aspect. And also clients are allowed to use substances in that building. We are heavily staffed with support people that will assist with clean supplies for use, teaching folks how to use in a safer manner, making sure that we're teaching opioid overdose response, and offering services so they can obtain housing. So the idea in that particular shelter is we're not asking the clients to do much other than pursue housing. And we have housing case managers on staff, a substance use disorder counselor on staff, mental health counselors on staff as well, to help support. So part of the good neighbor policy in that area is, although they're allowed to use in the building there, they're not allowed to use on the grounds outside.
Thank you. There's an incredible amount of research on the Seattle DESC programs specifically, and Amanda's going to drop a link to some articles in the chat if you're interested in checking those out. And speaking of evidence, I actually want to turn back to Dr. Pauly for a moment. You have a lot of experience with housing first models from a global perspective. And some people may hear about these types of programs and think that they're encouraging people to drink or to use drugs. People may also worry about something that you alluded to earlier, which is the cost effectiveness, the burden borne by taxpayers. But the evidence seems to suggest otherwise, that they are cost effective, that they lead to even reductions in unsafe use. So can you explain that, how that can be?
Yeah, it's really based on the fact that it's much cheaper to provide someone with housing and supports than to pay for shelter spaces, jail spaces, hospital beds. Those are very expensive ways to deal with homelessness. And there's some very good research out of Seattle, actually, by a Rankin is her last name. I just forgot her first name. For Sarah Rankin. And she highlights how much more expensive it is to manage homelessness through things like bylaws, municipal kinds of policies and sweeps. And not only are those things inexpensive, they're ineffective. Because we, for about 10 years, my colleague Tim Stockwell and I have been leading research on managed alcohol programs. And what we found is, that's a group of people, they're just left out all the time, right? Like there's no place for them, even more than, as much and more than illicit drug use in our communities. And they're just going round in this circle. They're on the street, they might get picked up and put, in a cell, they might end up in the hospital emerge department. Very expensive way to respond to an issue and totally ineffective. Because when we talked with them and we mapped out what was going on, not only were they in more expensive spaces, they weren't getting the services that they needed. They were getting a ticket for being inebriated in public. So it was, those kinds of things. And so when you look at the costing, there's the actual real dollars, and I can talk about those in a second, but there's actually the fact that it's costing us in terms of the fact that we are not providing appropriate care to people and they're getting missed out in care. In terms of the actual dollars and cents, we did one economic costing of a program. It was a managed alcohol program in Ontario, fairly small program, but roughly it was saving between this was very conservative estimate. It was saving about $1.09 to $1.21 for every dollar invested, which amounted between $2,500 and $6,000 a year per person. That was very conservative, and people were getting the supports they needed. So it was costing less and people were getting services, not just being shuffled around from place to place and coming to more harm. And it was very poignant for me, Alex, when you talked about the vulnerability of being outside. I think one of the most difficult things in some of the research that I've done over the years of decades of work, a decade of working with people with lived experience, has been hearing the stories of people who have come to harm outside, and they're trying to sleep and they're assaulted. And so, now we have people in a safer place getting more services, and wow, it's costing us less money to do that. And I'll just mention lastly, the Housing First model. The studies that have been done, I think it was December 2020 was the most recent, found that probably $1.17 to probably $2.80 are being saved for every dollar invested. So, when originally Housing First did economic costing, they were only basing it on the highest needs clients. So the savings for the other clients weren't really coming through. And that analysis has now been extended to a broad range of people. And so that's why you see, like $1.17 to like $2.80, because it really does depend on, the needs of the person in terms of the cost. But one thing I noticed with the managed alcohol work that we've done is that some of those individuals have been so overlooked for service for so long that it looks like they're very low cost, which is horrible, frankly, because they have high needs. they've just been completely overlooked. And I have to, I'll tell this crowd, because I think you'll appreciate it. I had to argue really, really hard with our economists to say, yeah, they've been homeless and they haven't been costing anything outside, but they deserve and have a right to housing. So you have to cost everybody at a baseline of having at least a decent, standard of housing. And so these costing estimates are really interesting, but every one you look at, they come out in favor of providing housing first with supports. And then I just really, really want to stress that other point that I made earlier is that, and people are also getting appropriate, they're getting services and they're getting appropriate services, which they didn't have before, which means that even if it costs more, that's a good thing. But it doesn't, we're finding it costs less.
We'll be heading into breakouts in a half an hour and be thinking about solutions for our own community. And as we do that, it'll be helpful to think about the infrastructure that we might need. And so I understand there are 10 key elements of infrastructure that are needed for harm reduction in residential and hotel settings. Can you talk a little bit about that?
Sure, thanks for the question. I just want to give a little background to this. For many, many years, been working in harm reduction, and my first introduction into harm reduction was really learning from other nurses who were outreach nurses, and it's really foundationally about the relationship that you have with people and accepting them as people, seeing them as human beings regardless of where they're at. So the substance use kind of takes second, is somewhere in the background. It's really about celebrating that individual and building the connections to that individual that are possible when you're not saying, in order for me to do anything with you, you have to get treatment first. That doesn't make any sense because people need help now. So about, again, a year ago when at the start of COVID, we had our shelters went to reduced capacity. Hours of harm reduction services like our overdose prevention sites were reduced. So we ended up with a situation where we had a lot of visible homelessness, which we hadn't had for some time. I mean, there were definitely people living outside here, but they were in pockets, and this just like people just had nowhere to go, literally. And so we ended up in a situation with several fairly large encampments, and the province made the decision that they would purchase some hotels for people to move into, which I mentioned earlier. And when they did that, our health authority turned to a number of organizations in the community, smaller nonprofits. One of them was Solid Outreach, which is a peer-run harm reduction organization, AIDS Vancouver Island, and Peers, which was an organization for people who do sex work. And they turned to those organizations as 3 harm reduction organizations and said, we need to come up with a plan because we don't want to move people inside only to have them overdose and die. And so the specific kind of part of harm reduction was we needed to think very pragmatically about what needed to be in these settings, in the hotel settings for harm reduction services. So I'm a community engaged researcher, so I do lots of research that would be very scientific, practical, but also practical. And so we, building on kind of the evidence, we built this 10-point plan, we called it, for infrastructure for harm reduction. So I'll just quickly touch on the 10 points. It is available on our website, which you see there. It's a little document that spells out what's in each of these sections. So the first one is having harm reduction supplies available at the front desk or from designated staff. The second one is having resident peer harm reduction workers. And the vision was to actually have people available who live in the hotel or could be in a housing unit as well, who would be available to do what we call peer witness injecting. And we've got quite a lot of provincial guidelines about peer witnessing, and to do education and to be trained in use of naloxone to help with distribution and also with social support as well. Having nursing support to access safer supply. In the province of British Columbia at the start of COVID, we had guidelines introduced so that substitutions could be provided to the illicit drug market, particularly for opioids, benzos, and stimulants, and that's still ongoing. And so nurses being able to connect with prescribers who could do that. The overdose prevention service, having a dedicated space, it could be a formal overdose prevention service, which is kind of what they went with originally, but it could also just be a space for supply distribution, witnessed injection, and connections to safer supply. Having inhalation services, because we have a high rate of people that would be smoking rather than injecting. And we've been successful in a couple of the hotels in getting designated smoking spaces. Having connection to virtual services and supports, really important. The wellness checks, this can be used in good ways and it can be used in not so good ways. And we've seen the whole range where people, are using it to surveil and monitor people, which is not the intention. It's rather to check in with people, once a day and see how you're doing and help them to get connected, not just to harm reduction services, but to other social services and supports. Because when you move people into the hotels that have been outside, I mean, survival is hard and a lot of their day is focused on survival. And when you move inside, and there isn't that sort of day-to-day survival, there also isn't their community that was there in some cases. And so then sometimes substance use increases as a way of coping. And so it's really important that people have social supports and social connections and activities that they can get involved in as well. Mobile services and supports, this was really there if something can't be provided on site, that, for example, I remember we did this during COVID. So, for example, we had worked out a system where there would be mobile delivery of harm reduction supplies to the resident peer worker who would then be able to distribute it. And this would also include other types of supports. Coordinating with services providing alcohol delivery. I mentioned we've been doing managed alcohol research for 10 years, and managed alcohol programs prior to COVID were very much integrated into residential community settings. And during COVID, what happened is it moved to more of a delivery kind of model, and having harm reduction and outreach workers and nurses being able to come in and support people with the management of their alcohol in a wide range of settings. And we're just doing evaluation of some of the new models. And then lastly, everybody needs harm reduction training. They need to understand what harm reduction is. We've been extremely skilled. We've been extremely educated in terms of abstinence and what that means. We need the same level of sort of reorientation to harm reduction. And then just lastly, the quick response. How are these harm reduction? The housing is funded by the provincial government, and the harm reduction and health services are funded by our health authority.
Thank you, Dr. Polly. Another group of individuals who frequently face discrimination in recovery housing settings is people who are on FDA-approved medications for opioid use disorder, like methadone and Suboxone, or buprenorphine rather. However, the Oxford House is a global model that's medication friendly. So our third panelist, Brittany Allen's been patiently waiting. Brittany is an Oxford House Outreach Services worker, and she's here to talk a little bit about their model. Hey, Brittany.
Hi, everybody. Thanks for having me. So first and foremost, what are Oxford Houses? Oxford Houses are self-run, self-supporting recovery homes. When our national report came out in February, March of this year, we had over 2,500 houses in the United States. Each Oxford House is home to people in recovery from drugs and alcohol, and also those with co-occurring mental illness. Each Oxford House is just a rented, ordinary, single-family home. The residents are same sex, and they receive a no-cost charter from Oxford House that states that the group must be democratically ran. The group, following the Oxford House model, the group must be financially self-supporting, and the group must immediately expel anybody that uses drugs or alcohol. So how does Oxford House work? Each Oxford House is ran autonomous. Now, specifically here in Kentucky, we do have a set of guidelines, and more in the in the North Midwest region, they follow the same core group of guidelines, but the residents govern themselves. They elect house officers with term limits. They hold regular house meetings, and they following the disciplined parliamentary procedures. Each resident works. They have a full-time job to pay their own rent and the rest of the household expenses. A good thing about Oxford House is there are no time limits on residency. So if an individual wants to live in a house for 6 months, they can. If they decide that they want to live there for the next 10 years, that's also something that they can do. DePaul University in Chicago has done studies on Oxford House, and more than 80% of Oxford House residents remain in recovery for long term, despite that many of them come from different backgrounds that have lengthy and alcohol and drug use, homelessness, and periods of incarceration. Our whole model is based on self-sufficiency, so we teach them completely how to be self-supporting. We are MAT friendly. Any kind of medication that a doctor prescribes you to be on, you are allowed to be on in an Oxford House.
Thank you. And you've also shared personally something that I'm really excited to get to ask you about, because I've had a similar sort of experience, and I appreciate your willingness to answer this, but you shared that you've had a change of heart regarding medication for opioid use disorder.
Yes, so
from an abstinence lens yourself. Can you talk a little bit about that?
I did. So when I first moved, I am in recovery. When I first moved into an Oxford House 5 years ago, I've been with the organization for 5, hired for a little over 2 at this point. I was one of the complete abstinent people. I didn't believe in any kind of medically assisted treatment at all until I started seeing people. I started being able to provide the oversight in these houses that individuals need, which is part of my job. And I started seeing people on the different medically assisted recovery that did extremely well. And eventually they end up transitioning out of our houses, and some of them are still doing extremely well.
Thank you for being willing to share that. We appreciate it. There are other programs in Kentucky that do work to address barriers to emergency housing through funding assistance. Kentucky Access to Recovery is an example. In other regions of our state, at Voices of Hope, we have a benevolence fund that's designed to be unrestricted funds to bridge gaps in housing. And Ryan White is another example of a robust program to help with emergency housing. So now I think we've got Robert Parrish joining us to talk some more about this critical program in the state of Kentucky. Mr. Parrish, are you with us?
I'm here, yes. I was sort of a late addition to the agenda, I believe. But yeah, so just to give everyone a brief overview of Ryan White, it's a big public health program in the U.S. for people living with HIV/AIDS, and assist them with accessing their medical care and other supportive wraparound services. So I'm a social worker by profession, and I work at the Bluegrass Care Clinic at the University of Kentucky, which is the infectious disease clinic at UK. And we are, I guess, the second largest Ryan White grantee in the state, and we serve the whole eastern half of Kentucky, so 63 counties total. And a few years ago, we had an opportunity to expand our funding for our supportive services. And our thought was to kind of try to get ahead of the opioid epidemic, at least within the HIV population. At the time, the percentage of our patients with an IV drug use risk factor wasn't particularly high compared to the national rate. It was relatively low. So with the growing issues with opioid use in Kentucky, we decided to expand our housing funding. So our funding is from HRSA, and there's not really a whole lot of guidelines to tell us how to provide housing. So we did a lot of research, and what we decided to do was do our best to model our housing funds using the Housing First model. So basically what we're able to do is we can house up to 20 clients at a time, at any given time throughout the year. These are, of course, only people who are living with HIV. And we try to target patients for that program who have specific high-risk factors. So issues of addiction would be one, people who are not adherent to care. And generally, the patients that we serve in our housing program have multiple issues going on. So mental health issues, substance abuse, and homelessness. And so we do not require clients to be sober to participate in the housing program. In fact, like I said, we target patients to enroll who are struggling with addiction and mental health issues. They're followed by a housing case manager who is a social worker. And this person does monthly housing care plans with the client to not only address housing, but also the issues that are contributing to some of the instability with housing. So in keeping with the Housing First model, we obviously would encourage the client to work on addiction issues as part of their housing plan, but that could be anything from getting connected with a support group or getting connected with a MAT provider. It doesn't necessarily mean you got to go to rehab in order to participate in the housing program. And so they follow that client, check in with them at least monthly to make sure that they're at least trying to make progress on their housing plan. And then in exchange for up to 2 years, we would provide housing and utility assistance to that client. There's one caveat a couple caveats to the assistance. First of all is we aren't able to pay deposits for apartments, so we have to rely on collaborations with other agencies within the community to sometimes get deposit assistance. But we're also payer of last resort funding source. So if there are other, resources available in the community, we're supposed to use those first. But I hope that's a good overview of what you all were looking for, and thank you for inviting me.
That's great. Thank you for joining us there, Mr. Parrish. And we're grateful for the housing that you all are providing. And we're also grateful that there are so many programs in central Kentucky and across the nation that provide housing for people in abstinence-based recovery. And we could certainly always use more. But in our state, there's a huge gap for housing for people who are using drugs and alcohol, or for people on medications for opioid use disorder. So Dr. Pauly, I want to turn back to you one more time, if that's okay. Just as we're about to launch into our breakouts, from your experience, what advice do you have for us? How can we get started with Housing First initiatives in our state?
It's a really great question. And it's causing me to reflect back on kind of where I think we've been. And I wouldn't say in Victoria, where I live, that we've been really successful with Housing First. And that's because we haven't had a supply of housing. And it's made it very difficult to do Housing First if you don't have housing for people. We have a real short. Housing here is very, very expensive. It's got very low vacancy rates. So, we're struggling with that part. The part we've done better, I think, has been to integrate harm reduction services into the housing we do have. And I think that's really significant because, a Housing First approach that integrates harm reduction could be implemented in any existing setting that you have already. And Alex, you made a very, I think, astute comment. It is, and this is probably a piece of advice learned from early on in our experience, was that we're not going to we need abstinence-based recovery housing. Many people enter into a harm reduction focused housing, then once they're stabilized, want to go to treatment. And that's what it means to be self-determining. You can make the choice any day to do that, and you should be able to do that. So when we think about Housing First, it's also thinking about a range of abstinence-based and harm reduction-based housing so that there's a place for everybody. So, I think what kind of happened in some places is the pendulum kind of swung and like, okay, we're all doing harm reduction housing. And people were saying, but no, I'm coming out of treatment. I'd like to go into a place that's free of drugs and alcohol. And that's legit, right? But if we keep it on self-determination and client focused choice, and we have the range of programs, we're going to do a much better job as a system. And one of my favorite stories, this was actually, we wrote a document called Housing First and Harm Reduction, I think in 2011, so 10 years ago, for our regional authorities. And we sort of laid it all out, and I'd be happy to share it with you. Even though it's older, it was introduced at a time when we were struggling with some of the things you're struggling with, having only abstinence-based housing. And one of our organizations, who was strongly abstinence-based, read the document and they looked at it and they said, I get it. This isn't what I do, but we need some people to do this. And I thought that was really profound for an organization who was deeply, deeply committed to abstinence-based approaches only, saying, we recognize what we do, and we also respect and recognize what other people need to do, because it's completely inhumane to leave people living outside with very few supports, or putting them in shelters where it's really hard to recover in a shelter. And, we really need to take up that housing as a human right. And really, that's what Housing First as an approach does. So those are some of my thoughts, just reflecting back over some of our experiences.
Thank you for sharing. And we're thankful to all of our panelists for your expertise and your guidance. And we're hoping that this is just the beginning of an ongoing dialogue, because we have lots of work to do in Central Kentucky and across the nation to provide housing for our friends who are actively using or who are on medications. To that end, we're now going to move into our breakout room.